Module 2 lecture, Chapter 15, Concepts of Infusion Therapy. The priority concept in this chapter is fluid and electrolyte balance. The interrelated concept is tissue integrity. Infusion therapy refers to the delivery of medications in solutions and fluids by parenteral route. Intravenous therapy or IV therapy is the most common route. It's used to maintain or correct fluid balance, maintain electrolyte or acid-base balance, or correct that as well, administer medications, or replace blood and blood products. Normal serum osmolarity is between 270 and 300 milliosmoles. Isotonic is 270 to 300 milliosmoles. Hypertonic fluids are greater than 300 milliosmoles, and hypotonic fluids are less than 270 milliosmoles. Table 15.1 on page 287 in your book reviews the different tonicity of common IV fluids. You need to know and be able to identify if a prescribed fluid is hypertonic, hypotonic, or isotonic. And then also know the expected outcomes. Know to monitor patients for any adverse effects and if the prescribed fluid is appropriate or safe for your patient. Isotonic infusate. When an isotonic infusate or a solution that is infused into the body is used, water does not move into or out of the body cells, and it remains in the extracellular compartments. Therefore, patients, especially older adults, who are receiving isotonic solutions are at risk for fluid overload. Some examples of these solutions include normal saline, 0.9% saline, 5% dextrose in water or D5W, and Ringer's lactate. Hypertonic solutions are used to correct altered fluid and electrolyte balance and acid-base imbalances by moving water out of the body cells and into the interstitial spaces in bloodstream. Electrolytes and other particles also move across cell membranes across a concentration gradient from higher concentration to lower concentration. Examples of hypertonic infusates include D5 dextrose in 0.45% saline or D5.5, 10% dextrose in water, D10W, and parenteral nutrition. As a note, parenteral nutrition also has a high pH and should not be infused through a peripheral IV. It needs to be infused through a central IV. Hypotonic infusates. Instead of moving water out of cells, hypotonic solutions move water into the cells to expand them. An example would be half normal saline or 0.45% sodium chloride. Prescribing infusion therapy. Nurses must be knowledgeable about all of this information. You need to be able to account for all of this information as well. So fluids, know what type of fluid is being administered, the rate in milliliters per hour or total amount of fluid in hours for infusion, and any drugs and dose is going to be added. Some drugs that are going to be in fluids, you need to be sure you list the drug name, the specific dose and route, time of administration, length of time for infusion, like the number of doses per days, and the purpose. The action alert on page 288 in your book says that you need to determine IV prescription if it's appropriate for that patient. If you have any questions, clarify that with the provider before you administer, and then check for accuracy and completeness of the treatment prescription. For instance, 5% dextrose in water to keep the vein open, or KVO, TKO, does not specify the rate of infusion and is considered an incomplete prescription. Vascular access devices. There are types of catheters used for peripheral and central IV therapy. Short peripheral intravenous catheter, or PIVC, a midline catheter, peripherally inserted central catheter, PIC line, non-tunneled percutaneous central venous catheters, tunnel catheters, implanted ports, and hemodialysis catheters. The vascular access device, or VAD, is a plastic tube that's placed in a blood vessel to deliver fluids and medications. The location of the VAD, either a peripheral vein or a large central vein, is determined by the specific type and purpose of the therapy. So as a review from pharmacology, peripheral IV therapy are short peripheral intravenous catheters. They're go in superficial veins of forearms, external jugular in case of emergencies. They're only about 3/4 to 1 1/4 inch in length. 26 gauge is your smallest gauge, and it goes all the way up to 14 gauge. There's no specific time frame for dwelling, and we want to assess those sites every 8 hours. For vulnerable patients, like your pediatric patients, you would reassess those for every 1 to 2 hours. Catheters should be removed and or rotated to a different site based on clinical indications, like signs of phlebitis, which is warmth, tenderness, erythema, hyperpigmentation, or palpable venous cord, signs of infection, or malfunction. This process requires conscientious and frequent assessment of the site. Table 15.2, page 289 in your book, helps you with choosing the gauge size for peripheral catheters. The smaller the gauge, the slower the rate you would want to go. Approximate flow rate, for instance, 24 to 26 gauge catheters is a 24 milliliters per minute flow rate. And it's preferred for infants or smaller children. Your larger gauge, such as your 18, 20 gauge, is preferred for adults. Best practice for patient safety and quality care. Verify that the prescription for infusion therapy is complete and appropriate for infusion through a short peripheral intravenous catheter, PIVC. For adults, you want to choose a site for placement in the upper extremity. Don't use the wrist. You want to choose the patient's non-dominant arm when possible, and start distally, and you will make all subsequent venipunctures proximal to previous sites. So start low and go up. Do not use the arm on the side of a mastectomy, lymph node dissection, arteriovenous shunt or fistula, or paralysis. You also want to avoid choosing a site in an area of joint flexion and choosing a site in a vein that feels hard or cord-like. Avoid choosing a site close to areas of cellulitis, dermatitis, or complications from previous catheter sites. The vein needs to be of appropriate length and width to fit the size of the catheter required for infusion. When you're starting an IV, you want to limit the unsuccessful attempts to 2 per clinician. If you're unable to get it after 2 attempts, escalate that to a clinician with a higher level of skill, such as someone from an IV team or another nurse, or consider an alternate route for the medication. Intermittent infusion of peripheral IV therapy. So this is for patients who need IV access but are at risk for fluid overload or don't need additional IV fluids. The peripheral vascular access device can be converted into an intermittent IV lock, also called a saline lock. This device allows administration of specific drugs given via IV push, such as Lasix or furosemide, or an intermittent basis using a medication administration set. IV antibiotics are frequently administered using the saline lock, and for many patients, the saline lock is placed in case there's a need in an emergency situation. The intermittent device is flushed with saline before and after drug administration to ensure patency and prevent occlusion with a blood clot. These should also be flushed at least once a shift. They're not recommended for obtaining routine blood samples due to the risk of hemolysis. Site selection. Dorsal venous network, so you want to avoid the hand for older adults. So this picture on the left shows you the different veins that you can choose when choosing an IV. You do want to use aseptic skin preparation and technique are crucial to prevent catheter-related bloodstream infections, or CRBSI. So skin prep. Aseptic skin preparation technique are crucial to prevent that. So remember the mnemonic HANDS. H, hygiene. Wash your hands. Use gloves before inserting peripheral IV. Ensure that skin is clean. Clean with soap and water if it's visibly soiled. Antisepsis is prepare the clean skin with a skin antiseptic like chlorhexidine or alcohol or propione iodine. With a back and forth motion for 30 seconds, allow the solution to dry before beginning the insertion. No touch. So once that area has been prepped, do not touch the site. And then document. You want to document the assessment of the site, the dressing, tubing. Ensure that the data is clear for all infusion sites. And scrub the hub of the catheter site with an alcohol pad for at least 15 seconds each time you access an infusion site. Midline catheters. Midline catheters are usually 3 to 8 inches long and can be either double or single lumen. They're used for fluid and drug therapy lasting longer than 6 days and up to 14 days. They can actually dwell in a patient up to 28 days. You don't want to use it for vesicant or parenteral nutrition. A strict sterile technique is used for insertion and dressing changes for a midline catheter. They're usually done by an advanced practice nurse, such as someone from the IV team, for placement. When using a double lumen midline catheter, you don't want to administer incompatible drugs simultaneously through both lumens because the blood flow rate in the axillary vein is not high enough to ensure adequate hemodilution and prevention of drug interaction in the vein. Central intravenous therapy is vascular access device that's placed in the central circulation, specifically within the superior vena cava, near junction with the right atrium. A chest x-ray is usually done to confirm placement. Other ways to confirm placement may be a magnetic tip locator or an electrocardiogram. Blood flow in the SVC is about 2 liters per minute compared with about 200 milliliters per minute in the axillary vein. This impacts hemodilution and administration of drugs that are incompatible. Peripherally inserted central catheter, or PICC line. The length is about 18 to 29 inches, 45 to 72 centimeters. The tip goes into the superior vena cava. There is a sterile technique used for insertion to reduce the risk for catheter-related bloodstream infection. PICCs should be inserted early in the course of therapy, before veins of the extremity have been damaged from multiple venipunctures and infusions. Insertion methods using guide wires and ultrasound systems greatly improve insertion success. Chest x-rays determine placement if it's not placed under fluoroscopy or electrocardiogram tip locator technique. PICCs can accommodate infusion of all types of therapy because the tip does reside in the SVC, where the rapid blood flow quickly dilutes the fluids being infused. There are no limitations on the pH or osmolality of fluids that can be infused through a PICC. PICCs can be single, dual, or triple lumen. And there are such things as power PICCs, which can be used for contrast material injections. They can also be used for blood sampling. You want to teach patients to perform the usual ADLs and to avoid excessive physical activity and heavy lifting. Muscle contractions in the arm from physical activity, such as heavy lifting, can lead to catheter dislodgement and possible lumen occlusion. Non-tunneled percutaneous central venous catheter. These are inserted percutaneously with the catheter exiting the skin near the cannulation site. It's inserted through subclavian vein in the upper chest or jugular veins in the neck, usually about 7 to 10 inches long and can be up to 5 lumens. The tip resides in the superior vena cava. Placement is confirmed by a chest x-ray. These are for short-term use, most often in emergent care. Tunneled central venous catheters are vascular access devices that have part of the catheter lying in a subcutaneous tunnel, separating the points where the catheter enters the vein from where it exits the skin. This separation is intended to prevent the organisms of the skin from reaching the bloodstream. The catheter has a cuff made of a rough material that's positioned inside the subcutaneous tunnel. These cuffs commonly contain antibiotics, which also reduce the risk for infection. The tissue granulates into the cuff, providing a mechanical barrier to microorganisms. This is used for frequent and long-term infusion therapy, and examples include the Broviac, Hickman, and Leonard. Implanted ports. Implanted ports consist of portal bodies, a dense septum over a reservoir, and a catheter. A surgically created subcutaneous pocket houses the port body. The catheter is inserted into the vein and attached to the portal body. The septum is made of self-sealing silicone and is located in the center of the port body over the reservoir. The catheter then extends from the side of the port body. The incision is closed and no part of the catheter is visible externally. Therefore, this device has the least impact on body image. Venous ports may be placed on the upper chest or the upper extremity and may enter either the subclavian or internal jugular vein. They're most commonly used for the venous system, but they may be used in arteries, the epidural space, or the peritoneal cavity, with a port pocket located over a bony prominence. Implanted ports are accessed by using a non-coring needle. A common brand name is the Huber, that is specifically designed with a deflected tip. This design slices through the dense septum without coring out a small piece of it, thus preserving the integrity of the septum. Port access should only be done by formally trained healthcare professionals wearing a mask and aseptic technique. And when the port is not accessed, there's no external catheter requiring a dressing change. These ports are most often used for chemotherapy patients. And Drug Alert on page 296 says before giving a drug through an implanted port, you want to always check for blood return. If there is no blood return, withhold the drug until patency and adequate non-coring needle placement of the port are established. Serious extravasations of vesicant drugs can occur because a fibrin sheath may occur at the tip of the catheter, clot it, and cause retrograde subcutaneous leakage. We do want to flush after each use and at least once monthly between therapy. Hemodialysis catheters. These are very large lumens are needed to accommodate hemodialysis. The catheter should not be used for administration of other fluids or drugs except in an emergency. These catheters could be either tunneled or non-tunneled. Catheter-related bloodstream infections and vein thrombosis are the most common complications of these catheters. Heparin is injected and dwells within the lumen to maintain patency. And to prevent systemic anticoagulation and subsequent bleeding, the heparin must be aspirated from the lumens before use. Dialysis catheters are maintained by specially trained hemodialysis nurses. Nursing care for patients receiving IV therapy. Before catheter insertion, you want to educate the patient and the family about the type of catheter to be used, hand hygiene, and aseptic technique for care of the catheter, the therapy required, alternatives to catheter and therapy, activity limitations, any signs or symptoms of complications that should be reported to a healthcare professional. Then perform the nursing assessment. Know the type of catheter your patient has in place, the length of the catheter, insertion site, tip location. Beginning at the insertion site and working upward, follow the tubing to the infusion bag. You want to assess the insertion site and look for any redness, hyperpigmentation, swelling, hardness, or drainage. And when a midline catheter or PICC is used, assess the entire extremity and upper chest for signs of phlebitis and thrombosis. Assess the integrity of the dressing, making sure that it's clean, dry, and adherent to the skin on all sides. Any vascular access device dressing should be changed when it is loose or soiled. Change transparent, semi-permeable membrane dressings, such as a target arm, every 7 days. Check all connections on the administration set and ensure that they are secure. Check all labels on containers for the patient's name and fluid or medication. Be sure that the correct solution is being infused. The action alert on page 300 says avoid taking blood pressures in an extremity with any type of catheter in place. This may lead to infiltration for your PIVs or phlebitis for your PICC lines. Draw blood samples in the extremity opposite from all catheters and avoid venipuncture site above proximal infusing fluids, which may alter test results. Protect the external catheter, dressing, and all attached tubing from water because water is a source of contamination. Remind your assistive personnel to cover the extremity where the IV is located when giving the patient a bath. They can use a plastic bag or a wrap, tape it over the extremity to keep the dressing site dry. Precautions to prevent air emboli are required when changing the set or connectors attached to any catheter. However, central venous catheters require special attention. CVCs have a clamp or a clamp on each lumen that should be closed during this procedure. Use a 10 milliliter syringe when flushing to establish patency in a CVC. Although these larger syringes generate less pressure, it is still possible to reach excessive pressure levels if great force is applied to a syringe attached to a catheter that is partially occluded. Catheter flushing prevents contact between incompatible drugs and maintains patency of the lumens. Flushing with normal saline is the standard of care. In your critical rescue, flush the catheter with normal saline, but if you start to feel resistance, you want to stop. If too much pressure is exerted, it may lead to catheter rupture or forcing a blood clot into circulation. You also want to aspirate for brisk blood return. If no blood return, further assessment by a specialized nurse, such as an IV team, or further diagnostic studies may be needed. For a short peripheral IV catheter, usually 3 milliliters of normal saline is adequate to flush the catheter. For all other catheters, 5 to 10 milliliters of preservative-free normal saline is needed. You want to flush the catheters immediately after each use, using a push-pause method or pulsatile flush when flushing all centrally located vascular access devices. This screen talks about nursing care for inserting and removing a peripheral IV. This should be reviewed from pharmacology, but remember when you're inserting the IV to date and time, the insertion, your initials. When you're documenting, you're going to document the vein, the gauge length, number of times you attempted to insert, the patient's response, the type of dressing, any special barrier precautions, and provide the patient and family education. When removing that peripheral IV, you want to slowly withdraw the catheter from the skin after gently lifting and removing the transparent dressing. Hold pressure on that site until hemostasis is achieved, and then looking at the catheter tip to make sure that it's intact and that it was completely removed. And then document your time of catheter removal and the appearance of the IV site. Complications of IV therapy can either be local or systemic. Local complications include infiltration, extravasation, phlebitis, thrombosis, thrombophlebitis, ecchymosis and hematoma, site infection, venous spasm, and nerve damage. Definitions, causes, signs and symptoms, treatment, and prevention are summarized in Table 15.3 in your book. Systemic complications can include circulatory overload, speed shock, and catheter embolization, and those can be found in Table 15.4. Central venous catheter complications may include catheter migration, dislodgement, rupture, lumen occlusion, catheter catheter-related bloodstream infection, and those can be found in Table 15.5 in your book. Bundle to prevent catheter-related bloodstream infections. So proper aseptic hand hygiene is needed. Measure the upper arm circumference as a baseline before insertion. Maximal barrier precautions on insertion. Chlorhexidine skin antisepsis should be used. Optimal catheter site selection and post-placement care should be done. And then daily review the line necessity with prompt removal of unnecessary lines. The action alert, page 293, reminds you to flush the PICC line with 10 milliliters of sterile saline before and after med administration and 20 milliliters after blood draw. You do want to use a 10 milliliter or larger barrel syringe to flush. Smaller barrels increase the risk of catheter rupture. Older adult care. Remember, older adults, their skin is more fragile, so you want to remove tape and dressings gently. That may require adhesive remover solutions or an alcohol pad. Use of a skin protectant before application of the dressing can prevent skin tearing when the dressing is removed. And you can also protect the skin by placing a washcloth or the patient's gown between the skin and the tourniquet before inserting an IV. Subcutaneous infusion therapy. This should be a review from pharmacology. It's usually used for insulin therapy and anticoagulant therapy, and is beneficial for patients undergoing palliative care who cannot tolerate oral medications, or when IM injections are too painful, or when vascular access is not available or difficult to obtain. It can also be used for hypodermoclysis or clysis. This involves slow infusion of isotonic fluids into the patient's subcutaneous tissue for the purpose of slow, steady rehydration. It's short-term fluid volume replacement, and the most common sites are the front and sides of thighs and hips, upper abdomen, and area under the clavicle. Fluid is absorbed more readily from sites with larger stores of adipose tissue. Intraosseous infusion allows access to rich vascular network in the red marrow of bones. Trauma, burns, cardiac arrest, DKA, life-threatening conditions may be indications for use for an intraosseous infusion. A fracture in the bone to be used as a side is a contraindication. You want to monitor for compartment syndrome, which we will learn about more in Module 8. And intraosseous infusions are discussed in ACLS training. Intra-arterial infusion therapy is used to obtain repeated arterial blood samples, monitor hemodynamic pressures, infuse chemotherapy, or fibrolytics. It's used for 3 to 7 days, and the risk for complications increase during dwell time. These will be discussed in critical care modules. Intraspinal infusion therapy. Two spaces used for infusion are the epidural space between the dura mater and vertebrae and the subarachnoid space. Intrathecal medications infused into subarachnoid space and directly into cerebrospinal fluid. The primary indication is postoperative and persistent pain. The patient receives pain relief from the level of the injection toward the toes. Complications of intraspinal infusion therapy include infection, bleeding, leakage of cerebrospinal fluid, or CSF, occlusion of the catheter lumen, and catheter migration. Infection in the patient receiving either an epidural or intrathecal therapy could be the result of a lack of asepsis when handling the medication or during the administration. Evidence of local infection, such as redness, hyperpigmentation, or swelling at the catheter exit site, may be present. The patient may also exhibit neurologic and systemic signs of infection, such as a headache, stiff neck, or temperature higher than 101 degrees Fahrenheit. Report any neurologic change to the primary health care provider immediately. Intraperitoneal infusion therapy will be discussed in RNSG 2930. Question time. Question 1. A new nurse is preparing to insert a vascular access device in a client. Which action by the new nurse requires intervention by the experienced nurse? A. Performing hand hygiene prior to insertion. B. Preparing for insertion immediately following cleaning with iodophores. C. Using friction to clean the skin around the insertion site. Or D. Clipping the hairs in the preferred insertion area. The correct answer is B. Current recommendations call for using friction when cleaning the skin to penetrate the layers of the epidermis. Iodophores, such as povidone iodine, require contact with the skin for a minimum of 2 minutes to be effective. Skin should never be shaved before venipuncture, but excessive amounts of hair should be clipped. Question 2. During IV catheter insertion, a client with dehydration reports feeling pins and needles in the arm. What is the appropriate nursing response? A. Nerve puncture may have occurred. B. That is a normal sensation that will go away. C. It is likely that the vein I was accessing has collapsed. Or D. That means that the catheter is placed in the appropriate location. The correct answer is A. Reports of tingling, feeling pins and needles in the extremity, or numbness during the venipuncture procedure can indicate nerve puncture. The procedure should be stopped immediately, the catheter removed, and a new site chosen. Transection of the nerve can result in permanent loss of function, and local nerve damage can become a chronic systemic pain syndrome. This concludes Module 2's lecture on concepts of infusion therapy.